Welcome everyone, and thank you for attending Hospice and Palliative Care 101. What's the difference? I want to start by recognizing that I know this is a hard topic, as it makes a lot of us face difficult decisions for ourselves and or for our loved ones. Regardless, it is a topic that many of us want to know about. You're here today. And also, these are services that people want available. A 2019 survey by the Public Opinion Strategies Group found that 94% of those asked felt it was important for palliative care services to be available for patients with serious illness. So as was mentioned today, we're going to focus on that general information regarding palliative care, hospice care, the differences and similarities, how do you enroll, and how services are paid for. I wanted to include the tree of life picture on this slide, as when you look into information for palliative care and hospice care, you will almost always see it. It has become an almost unofficial symbol for this type of care because it represents the circle of life. As I start out, I want to start with this visual representation for palliative care and hospice care. As I was researching this presentation and when I worked in the field, and as many of you maybe have found, these two terms are often used interchangeably. They do have a lot of similarities, but there are also some very definite differences that are important to note. Palliative care is an umbrella term for the type of care that focuses on comfort. Hospice is one type of palliative care. So hospice will always be palliative care, but not all palliative care is going to be hospice. Both hospice and general palliative care are forms of medical care. They are not abandoning medical care, they're just a form of it. They focus on symptom control, pain relief, and quality of life. It does not mean that these programs come in and change everything about your health care. What it means is that they may suggest adjustments and hold discussions with you and your family about what can help you feel better. So what is palliative care? What does it mean? So it's a specialized type of service that focuses on people living with a serious illness. The main goal is symptom and stress relief. It's going to focus on improving the quality of someone's life by helping with the symptoms of their disease. The focus is improving each day so that people can live it to their fullest. Patients can receive both palliative care and curative care for their illness. This is very important to remember, as this is a major difference between hospice care and general palliative care programs. You can again get both curative care and comfort care at the same time when on a general palliative care program. Palliative care is appropriate at any age or at any stage when faced with a lifelong, potentially debilitating disease. I have often heard phrases like, they're too young, or they were just diagnosed. But as all of us know, we know that an illness is an illness, no matter how old you are or how young you are. And we also know that the sooner you address an issue, medically or in your own life, the easier it is usually to manage them. Therefore, stressing the importance of getting services involved early on. Palliative care can be provided in a variety of settings. Because palliative care is an umbrella term, the care can range from you having a consultation with a doctor that specializes in palliative care at a clinic or a hospital setting, all the way to a formalized palliative care team that comes to your home. I wanted to highlight how this would look with Adriana. So Adriana's story highlights what it would look like. Adriana has breast cancer and was receiving treatment. She developed anemia and became extremely fatigued. Palliative care got involved, and after discussion, Adriana agreed to receive a blood transfusion to help with the anemia. This helped to improve her fatigue, and she was able to continue with her curative treatments. Because she was on palliative care, she was able to get both the comfort care treatment of the blood transfusion for her anemia and the curative treatment of chemo for her cancer. Hospice care it's a form of palliative care that again specializes in the comfort care of a person. It's focused on caring for someone with a life expectancy of 6 months or less. This statement of life expectancy of 6 months means that if the disease that someone is on hospice for takes the typical route without intervention, it would be understandable that someone could pass away in 6 months. Excuse me. Everyone's situation is unique, and not everyone's disease will take a typical route. Some people are going to pass away sooner than that, and some people will be with us a lot longer. People can stay on hospice longer than 6 months if a doctor recertifies that their disease is still progressing and it still would be reasonable that someone would pass away from it in the near future. Hospice care is focused on comfort care. People receiving hospice are no longer getting curative treatments. Someone on hospice typically does not get chemotherapy, radiation, surgery, scans, etc. Sometimes people will say that they knew someone who did get these things while on hospice. And again, everyone's situation is unique and different. If something is focused on comfort care, not curative care, there are times that different treatments are used, but this would be the exception and not the norm. Hospice is appropriate for any diagnosis that may prove terminal without treatment or is no longer responding to treatment. It's important to understand that we all have a say in our treatment plans. When someone is given a diagnosis, they have a say in what type, if any, treatment they receive. This is a conversation for the patient, the family, and their doctor. Hospice can be provided in most settings. Often you hear about it in people's houses, in their nursing homes, assisted livings. Sometimes it's provided in hospital settings. I know I treated people in hotel rooms, and their hospice is set up even to go into prisons and jails. The goal is to take hospice to where a patient is. There are also hospice houses in some communities. They are pretty rare, but they do exist, where the focus of the care is on end of life. These houses would be similar to like a mini nursing home setting, but again, with the focus on individuals with a terminal illness. So as we've been talking, you can hear that there's a lot of similarities and differences between palliative care and hospice care. They both focus on comfort care, treating the symptoms of the illness or disease. They both focus on the whole person. They want to provide comfort for the physical, emotional, and if needed, spiritual symptoms that someone is experiencing. They can be provided in a lot of different settings. The team structures and diagnoses between the two are similar as well, and we'll discuss this in a minute. And I wanted to note that neither program moves in. No one is going to show up with a suitcase in hand. Both programs will have staff that can come to the person to assist with the management of their symptoms. They provide support, but the hands-on daily care is still provided by either the person themselves, their family and friends, and/or caregivers, such as in a nursing home, or ones that the person has hired for themselves. Also of note, a person can come on and off both of these programs as their wishes and conditions warrant. You do not need to stay on indefinitely if you do not want to, or if your condition improves, you can sign off. No one has to be on a palliative care program first before signing on to hospice either. The largest difference is what we've already discussed, and that is that curative treatment for the disease is only available under general palliative care programs and not hospice. The length of care is different too. For palliative care, it is usually focused on a specific issue, a source of discomfort that they're trying to address. Once it's addressed, palliative care may stop. However, sometimes we know issues are ongoing, and therefore palliative care may be longer term. Again, everybody's situation is different. For hospice care, once a member is certified by a doctor of having 6 months or less life expectancy, care continues until they pass away, or a doctor no longer believes that they meet criteria. They improve or they're no longer declining. Hospice programs are more numerous and are better understood than palliative care programs. According to the National Institute of Health, the idea of hospice care has been around since the 11th century, so it's been around for a while, and was officially established in the US in 1974. Palliative care has been in place in the United States since 1987, when it was founded as a medical specialty. Formalized palliative care programs came after that. Also, the programs are going to be funded differently, and this is discussed at the end of the program. So now into the nitty-gritty, palliative care. You're going to see a diagram on your screen, and this is going to discuss the services it provides. Now, please remember that this is going to be dependent on what program that somebody enrolls in. Every program is going to be slightly different, but this is what a typical formalized palliative care program would look like. At the center, you have the patient and the family. Of course, they're going to be the main focus. And by family, I mean anyone that's involved with the patient's life in an informal way. It could be neighbors, friends, family members, church members, whoever it might be. You also have physicians. So these are the doctors that are involved with that person's care. It could be your primary care doctors. It could be the specialists involved with the care. These people are going to manage your illness or disease. Now, obviously, doctors are skilled in symptom control, but if a situation is a little more complicated, it is often beneficial to have someone solely focused on the symptom control. And this is where the advanced practice providers would come in under palliative care. These would be like physician's assistants or nurse practitioners, and these are the people who are going to work to manage your symptoms. You can be supported with your spiritual concerns if needed, and you can also have a social worker available to help with the emotional needs, community resources, legal and financial needs that may arise. So for hospice services, you will see there's a lot more circles and a lot more people involved with hospice than with palliative care. And this is not because those services aren't available to people on palliative care programs, but because when someone is on hospice, the idea is that typically the services need to go to the person just due to the severity of their illness. Where on palliative care, the idea is that hopefully that person can go to those different services and utilize them as an outpatient. At the center, again, you're going to have the person and their family, and you're going to have the physicians. The physicians, so this is again, is going to be the doctors involved with their care, primary care physicians and specialists. But in addition for hospice care, you also have a medical director to help manage your situation. People on hospice can continue to see their doctors, but if they don't want to or aren't able to get to their doctors, the hospice medical director can oversee the care and talk with their providers. You're going to have spiritual counselors and social workers as well, like you did on palliative care, but if desired, they can address more of the end-of-life issues that may come up at this point. You also can have home health aides that can come in to help with some hands-on issues like showering, maybe changing linens, minor stretching, etc. Therapists. Now, I want to point out that this is not psychotherapy. This is going to be more your physical therapy, occupational therapy, massage therapy, etc. These folks will come in to look at stretching or other techniques to help with symptom management, maybe pain relief, anxiety relief, or to teach the family techniques to help provide the care more safely. So then you got nurses, and they're the ones that are going to come in consistently to manage the medications and symptoms and to kind of direct the other members of the hospice team. They usually will come in at least once a week, but they will come all the way up to daily as needed. Also with nursing, there's usually a 24/7 coverage, and this means that there's a phone number available for families to call when something happens or there are concerns. We know that those always happen at 1 a.m. on a Saturday night. So this is a phone number that they can call where you can reach someone who has knowledge and information on the situation and can offer direction or possibly even come out to make a visit. Hospice also has volunteers. These are people who can come in to spend time with the patient and or give the caregiver a chance to leave the house if appropriate. Finally, this is different between palliative care and hospice care as you have bereavement counselors for hospice care. And these are individuals who will follow up with the family post-death for 13 months. Common diagnoses for palliative and hospice care. Again, there's going to be a lot more than this, and this is just going to be a sampling. And sometimes people have multiple diagnoses that, again, qualify them for palliative care or hospice care. But some examples are Alzheimer's disease and dementia, respiratory disease, COPD, heart disease, cancers, Parkinson's disease, stroke, and renal failure. But I really want you to remember that the focus of palliative care and hospice care It's not the disease or the illness, it's the symptoms and how to make someone feel better. Again, you have doctors that are managing the disease or illness, where the hospice or palliative care team is focusing on those symptoms, those things that they can do to make your everyday life better. Common symptoms that are managed by palliative care and hospice care, this is going to be pain and constipation, anxiety and depression, skin issues, shortness of breath, and nausea. Again, these are just a few. They manage a lot more than that. And we also know that sometimes by treating one of the symptoms, it's going to help in other areas and, alleviate other symptoms. But again, every day and every situation is different, and they're going to continually strive to make that person comfortable. So then the question sometimes comes up, I'm ready. Now what do I do? So if you or a loved one at some point decide, I want palliative care or hospice care, I think that this is appropriate for me. The first step I always tell folks is you want to talk to your doctor. And this could be your routine doctor, your specialist. They're going to refer you to an agency after discussion that's appropriate for your situation. Now, I also wanted to point out that you can always complete a self-referral and call an agency directly. I always stress to individuals, you want to talk to your insurance company, you want to talk to your doctors, because they're going to get involved at some point anyway. Once you would call an agency, they're still going to need to talk to your doctors to get the appropriate paperwork, referral, and certification. Once a doctor has sent the information along to an agency, that agency is going to contact you and send out staff to do an assessment, explain the program, and how someone can sign on if interested. At that point, you still have the right to not sign on if it doesn't sound like the right fit for you. There was a question that came on about how someone could be on a service without their knowledge. It's kind of hard to speculate. I would think this would be more common if you were just having a one-time consultation or treatment in a hospital maybe, or you were getting an informational visit for palliative care, hospice care. But if you're signing on to a formalized program, documents do need to be signed by either the patient themselves, or if they're unable to, their activated power of attorney for healthcare can sign those forms. So how is hospice funded? Hospice, I want to stress that if you're a Medicare Advantage plan member, you still have Medicare. And typically your Advantage plan is going to manage the costs associated with your health care. Hospice is one exception though, and hospice is paid for through your Medicare fee for service. So again, even if you have an Advantage plan, you still have Medicare, and that's what funds hospice. If there would happen to be costs associated for your hospice care that aren't funded under the Medicare fee for service, they may get passed on to your Advantage plan, but I'm going to stress this is pretty rare. Usually the Medicare fee for service does cover most of the things related to your hospice care. Can't always guarantee, but it usually happens that way. What is included for the fees for hospice care are items and care related to your hospice diagnosis. I'm going to use that term related to your hospice diagnosis a lot here. So the fees will cover the hospice team, meds related to your hospice diagnosis. So again, your medications related to that diagnosis, equipment related to the hospice diagnosis, inpatient and respite care related to the hospice diagnosis. For example, if someone is on hospice for a cancer diagnosis, medications related to possibly their pain, constipation, maybe anxiety and depression, maybe a walker or wheelchair due to weakness, would be covered on a hospice due to its connection with the cancer. But if that person would also be on, say, cholesterol meds or eczema cream, these would be handled as they were prior to going on hospice, as they are not related to the hospice diagnosis. Again, anything that is not related to the hospice diagnosis, it's going to be paid like it was prior to being on hospice services. For palliative care, outpatient care is going to be looked at just as it was a routine visit with any other doctor. And this is paid for through your Advantage plan as your other visits are. It's going to be subject to the cost sharing and deductibles like every other visit. If you would need to go inpatient for a palliative care diagnosis, This is billed as hospital stays are, again, subject to that cost sharing and deductibles. Now, for more information, if you want information on specific agencies that exist in your area, if you want information about coverage and you're a Security Health Plan member, we welcome you to call the customer service number on your member ID card to learn more about the coverage on your plan, or you can also review your plan documents. If you're not a Security Health Plan member, I would encourage you to contact your insurance company as they'll be able to offer you more direction. Thank you. And at this time, I'd open it up for any questions.
Well, thank you so much, Jen. That was awesome. I think we did get a few. If you give me just 1 minute here. Okay, so why don't we start with this first question that was received is, what are comfort cares?
Sure. So comfort cares are going to be, it's going to be medications, it's going to be equipment, it's going to be emotional support or spiritual support to help alleviate symptoms. It's those comfort cares are not going to be focused on curing a disease. They're going to be focused more on keeping the person's situation better managed so that they can be comfortable in their everyday activities. Again, with comfort cares, this is not to take away traditional medicines, especially if you're on a general palliative care program. This is just to come in and to assist so that someone is comfortable with their disease. Good example would be if you have COPD, to be working with potentially, oxygen, inhalers, different medications and equipment that possibly can assist you so that you're more comfortable in your daily life.
Okay, the next question that I am hoping you can address is, what happens if I still need cares after 6 months?
Sure. So if you're talking about being on hospice, you can remain on hospice care after 6 months if the doctor's still saying that your disease could potentially still be life limiting. It's still expected that disease will potentially cause someone to pass away. The only times when hospice would stop is if a person improves, which sometimes does happen, and they improve consistently, say for over weeks at a time, or if someone's disease just isn't progressing at a normal rate. And usually this has to be pretty pronounced for someone to get signed off of hospice services. So it is quite common for people to stay on hospice longer than 6 months, but they do need the hospice director and or their medical providers to be signing documents saying that they anticipate their disease is still progressing.
Okay. Who do I talk to or talk with if I have a specialist?
About if the question is about getting palliative care or hospice care, it would be to talk to your specialist. So it could be to talk to the doctor themselves, or if they have a nurse that works with them, you can talk to them. And if you're interested in palliative care or hospice care, you can bring it up and say, I would like to talk to my doctor about potentially getting on a palliative care or hospice care program. And then that's hopefully where that dialogue is going to happen, where the doctor can talk to you about what your options are regarding that, or if they don't think it's a good fit, why and how they can provide supports to you at that point.
Okay, hopefully that answers that person's
Yeah.
question. Another question that we had was, can somebody come to my house and talk with me? If so, how do I set this up?
Sure, absolutely. Hospice and palliative care programs, if it's a formalized palliative care program, do come out and make informational visits is what we would call them, to people quite often. And so what you would do is you would talk to your doctor and say, you'd like some more information about hospice services or palliative care services, and they can work with you to contact those agencies, and then they will call you to set up a visit. I know when I worked in the field, we did a lot of informational visits in people's houses. If somebody was in a hospital and wanted that information, we go to the hospital, wherever that person was or their family was. we really did strive to give them informational visits before we enrolled them, just because we wanted to make sure that they understood what the programs were about.
And we had one member of the audience make this comment that I want to include. It says, I have many Medicare Advantage members. I have had members enrolled with interim and ProMedica Palliative. These home health agencies have nurse practitioners and, sorry, I'm not sure what SWs are. Social workers.
Social workers. Mhm.
Yes, okay. Who provide home visits. Palliative care is covered, provided by an MD or an MP, which includes domiciliary care in the home, rest home, and assisted living visits are all covered. Copay does not apply if meeting Medicare criteria, and palliative care may be covered in a hospital setting if the member requires acute care. Security Health
Correct.
Plan does not require use of an affiliated palliative care provider. That's great information, Sherry. I wanted
Wonderful.
to make
Thank
sure
you.
that we were including that in the
Thank you.
recording. And then why don't we have one last question here?
Okay.
It says, my primary care provider has never brought this up. Can I talk with him or her about this?
Absolutely. I touched upon this, 20 minutes isn't a lot of time to touch on everything, but you have a part in your treatment plan. So I encourage anybody who thinks that they would like more assistance, if they would welcome this kind of information, to talk to their doctors. Sometimes doctors don't think to bring it up. Sometimes doctors, for whatever reason, it's just not foremost on their mind, where it is on yours. So please bring it up to your doctors and discuss it with them, and they can obviously assist you in getting that appropriate information that you need to make those decisions.